Good afternoon, everybody. My name is Vipul Jareth. I'm VP of Medical Research and Development here at Alimentiv and Professor of Medicine at Western University in Canada. I'd really like to welcome everybody to our third live stream event today. Our last live stream, which many of you joined in October on the topic of precision medicine, had more than 400 attendees. And I'm very pleased to see that almost 600 people have taken time out of your busy schedules today to join us. And for what will be a very interesting topic and fantastic panel of speakers. Our topic today is targeting intestinal fibrosis and inflammatory bowel disease, and we're really fortunate to be joined by some of the experts in our field, both from industry and academia, whose vision and efforts have really helped to move this field forwards. The format of today is going to be very similar to our last event, where there'll be an integration of basic science, clinical medicine, and drug development pathways. Just some brief housekeeping. The keynote presentations will be followed by a panel discussion chaired by Professor Iris Dotton. All of our lines are muted, but you can submit questions throughout in your chat box, and we'll select some of those for the panel. Questions that we can't get to, we will absolutely endeavour to answer those by email. So I'd like to start by introducing Professor Iris Dotton. Iris is Director of Division of Gastroenterology at the Rabin Medical Center in Israel. She received a medical degree from the Sackler Faculty of Medicine, and her postdoctoral fellowship was in immunobiology at Mount Sinai, New York, where she focused on intestinal epithelial cell biology. She has a very diverse clinical and basic research practice, and translational research focuses on immunology and the interactions mainly between intestinal epithelial cells and mucosal lymphocytes. She also has a very large and long-standing interest in patients with ulcerative colitis who've undergone proctocolectomy and pouch formation. She's extensively published. She's the past president of the Israeli Society of Gastroenterology, and she's the vice chair of the IOIBD. And thank you very much, Iris, today for chairing this panel. So without further ado, I'd like to introduce our first speaker, Dr. Thomas Wynn. Tom is Vice President of Discovery in Inflammation and Immunology Research at Pfizer. Prior to joining Pfizer in 2017, Tom was Chief of Immunopathogenesis section at the NIH in Bethesda. He's published over 300 papers in many prestigious journals, and his work has really made a substantial contribution to our understanding of the role of cytokines and growth factors in the progress and resolution of inflammation and fibrosis. His work's also focused on the role of macrophages, fibroblasts, and stem cells in repair and regeneration. And Tom's been cited as one of the most highly cited researchers in the field of immunology by Thomson Reuters over the last 5 years. So again, thank you very much to Tom and all of our speakers, and I'll hand over the floor to you.
Well, hopefully everybody can hear me. Thanks, Iris and Vipul, for the kind introduction. I'm really pleased to be here. I was asked to give a very quick review of fibrosis, so we're all on the same page. And Julian and Florian will really dive in deep on the impact of fibrosis, intestinal fibrosis in IBD. So I thought I'd just start off with a little bit of background. What is fibrosis, and why is it a problem? Whenever you injure tissues, disrupt those tissues, there's an inflammatory response that's induced. And really that early programmed response is all about dealing with any potential invading microbes that might pose a risk. So there's an initial inflammatory response, innate immune response to try and deal with any invading organisms that might accompany that tissue injury. After that initial inflammatory response to deal with the microbes, an inflammatory response develops to try and heal the tissue. So there's a clotting response that happens to try and close off any fissures in the endothelial cells, any happening. And then there's an inflammatory response that's orchestrated to try and repair those tissues. And a big player in that repair response are macrophages, which come in many different flavors, different activation states. They produce growth factors, and other mediators that activate fibroblasts, which are key to tissue repair. And so in that next stage, after this inflammatory response is induced, the goal is to regenerate those tissues, restore normal tissue architecture. And when you have an acute injury, this wound repair response, this inflammatory response that orchestrates the tissue repair through activation of fibroblasts, is very well orchestrated, and you get normal restoration of tissue architecture. In situations where you have chronic injury, chronic invader, you have persistent injury of some type, this inflammatory response that's driving the tissue repair can become imbalanced, and you get an excess deposition of extracellular matrix components that leads to a deposition of scar tissue. And while that scarring is initially okay, that's a part of our normal wound healing response, when you have a chronic injury over time, that fibrosis can ultimately lead to tissue malfunction, organ dysfunction, and ultimately death. So it's really a chronic disease that we're talking about, a chronic pathology that contributes to disease pathogenesis. And interestingly, while the inflammatory response is a major driver of the fibrosis, we've also appreciated over the past decade that an inflammatory response is also key to reversing the fibrosis. You actually need inflammatory cell subsets like macrophages that produce enzymes that degrade collagen to actually reverse the fibrosis. So inflammation can be both pro-fibrotic and it can be inherently anti-fibrotic. And that's probably why anti-inflammatory drugs in general have not been very successful for the treatment of chronic fibrotic diseases. Inflammation plays both a pathogenic role and a protective role, and we need to understand those different components. Of course, a big area of research for the past really 3 decades has been the fibroblast. It's the proximal cell that deposits collagen and other extracellular matrix components that leads to fibrosis. So there's been lots of attention on the origin that cause fibrosis, how they become activated, how they become deactivated, what is their lifespan, how do they proliferate, etc. So there's been a lot of attention on this really for a long time. And it's really gone through an evolution where I think early research was really focused on tissue resident fibroblasts, the fibroblasts that hang out in the tissues that are injured and the role that they play in the fibrosis. There was excitement and still is around the role of fibrocytes that are a bone marrow derived population of fibroblast-like cells that can contribute to fibrosis. There's been a lot of interest in epithelial mesenchymal transition and endothelial cells that transition into fibroblast-like cells, and how those different populations can contribute to the fibroblast pool that leads to fibrosis. And there's also a lot of interest around the role of pericytes, which are these fibroblast-like cells that line endothelial cells that can also become activated and contribute to the development of fibrosis. And I make special emphasis on the pericytes because I do think they play a really important role in fibrosis systems. Vasculature is found in all of our organs. These pericytes are found in all of our organ systems. And there's a really intimate interaction between endothelial cells and fibroblasts in the development of fibrosis. When you have injury to a tissue, there's typically a loss of vasculature as you develop scarring in that location. You basically eliminate the vasculature and it turns into scar tissue. And so there really needs to be crosstalk between those endothelial cells. And we think the pericytes play an important role. They actually crawl off the endothelial cells when they become activated and start secreting matrix that contribute to fibrosis. So understanding those interactions are continuing to be a central theme in the field of fibrosis. One of the things that's really changing our understanding and really improving our understanding of the pathogenesis of fibrosis are all the omics approaches that are coming on board. Proteomics, metabolomics, transcriptomics, all these different techniques, whole genome-wise analysis of tissues to gain a deeper understanding of the mechanisms and the various cell types that contribute to the activation of fibrosis or fibroblasts that lead to the development of fibrosis. All these omics approaches are becoming more and more integrated. We're getting a much deeper understanding. And we're even introducing techniques like spatial transcriptomics and proteomics. They're actually providing a window on what's going on in the diseased tissues. What are the cell populations in that area? What are the genes they're expressing, and how they might be interacting with the cell types in the same location where collagen deposition is happening. And this is really opening up our understanding of the complex interactions that drive tissue fibrogenesis. And another area that it's become very clear is that, it's not just fibrosis, but there's a greater appreciation of the role of fibroblasts, these resident tissue fibroblasts, and their role that they play in various diseases. There's really some fascinating work that's come out of the field of rheumatoid arthritis, that there are different subpopulations of fibroblasts in the lining and sublining layer of the synovium that play very distinct roles based on the genes that they express. There's a population that seems to be driving the inflammatory response. There's another population of fibroblasts that seems to be more tissue destructive. It can cause bone and cartilage destruction, so different subsets being identified with transcriptomics approaches. When you look at different organ systems, cardiac muscle, skeletal muscle, there's populations that play an important role in tissue homeostasis. And again, there's unique populations in those tissues that contribute to fibrosis post-injury. There's also some really beautiful work that's been going on looking at lineage tracing. Where are the fibroblasts coming from? There's this discovery that fibroblasts can transition into cells like adipocytes. There's a very close association between fibroblasts and adipocyte lineage. And there's also coming out of this work an understanding that we can possibly reverse the phenotype of the pathogenic fibroblast subsets, return them to a more quiescent tissue resident state, or actually through therapeutic intervention, turn them back into a resting fibroblast population, or possibly even reprogram them into a different population that can, again, restore tissue homeostasis in different organ systems. So a lot of cool work going on in the genomics, proteomics, transcriptomics front to get a deeper understanding of the role of these fibroblasts in fibrosis. Another thing I wanted to bring up that's been exciting over the past decade is 30 years ago, it was all about TGF beta, and TGF beta being a key profibrotic cytokine. Lots of beautiful work been published over the past 3 decades or more on the critical role of TGF beta in driving fibroblasts into myofibroblasts that secrete collagen and other matrix components. But that, over the past decade or so, there's been an appreciation that there are mechanisms of fibrosis that are independent of TGF beta. And I think for the development of therapeutics, it's really important to understand these mechanisms and pathways that can lead to fibrosis that are independent of TGF beta, because that will really dictate the level of success that we see. We need to understand those alternative mechanisms of fibrosis and how we may target them therapeutically. And that's what's shown on this slide. I think another thing that's exciting that's going on in the field of fibrosis is, animal models have been very informative in understanding basic mechanisms of fibrosis, certainly revealed lots of targets over the past several years through these experimental animal models. I think one exciting thing that's happening to help us translate those animal studies into the human setting are organoid systems and complex culture models. This slide is basically just to suggest that it's not all about the fibroblasts. There's important interactions between epithelial cells, endothelial cells. All of these cell types are talking to each other to drive the response that leads to fibrosis. And I think the best way to understand that in the human setting is to develop organoid cultures that can incorporate multiple cell types into one system, or complex culture systems under flow, et cetera, that can help us translate those mouse findings to the human setting. And so I think that's a really exciting thing that's going on right now. Lots of companies, lots of startups, a lot of academic scientists are focusing on these systems to better understand the crosstalk. And a good example is the crosstalk that goes on between macrophages and fibroblasts. Macrophages are an important source of growth factors that activate fibroblasts, and fibroblasts in turn produce growth factors that help macrophages grow and expand. And when we look in the tissues where fibrosis is happening, we often see large populations of macrophages and fibroblasts in close association. So we're trying to use these complex systems to simplify them, to simplify the crosstalk and better understand the crosstalk, and hopefully identify new targets to intervene in fibrosis. And then one more slide here, just to dive in a little bit deeper on just why these types of systems for understanding this crosstalk is so important. Even when you just focus in on the role of the macrophage, it plays a really complex role in the pathogenesis of fibrosis. And the different phenotypes of macrophages we see at various stages of disease likely dictate whether the macrophage is pro-inflammatory and pro-fibrotic, develops a wound healing phenotype, or actually exhibits antifibrotic activity. There's different subsets of macrophages that get activated based on signals found in the local tissue microenvironment. There are inflammatory subsets that play a role in activating fibroblasts. Macrophages can then transition to a wound healing phenotype where they produce growth factors that target fibroblast or ECM production. They can target epithelial cells to induce reepithelialization and tissue repair. They can target endothelial cells through various factors that they produce and drive angiogenesis and revascularization of the tissue. They produce factors that target stem cells that play an intimate role in tissue repair. So these wound healing phenotypes really play critical roles in that stage of resolving the insult. And then they can also transition into an anti-inflammatory phenotype that turns off the inflammatory response that allows this wound repair response to proceed. And so all these different phenotypes play key roles at different stages of fibrosis. And we understand those different phenotypes and figure out ways to activate those distinct populations to hopefully resolve disease. I'm just going to end with one more slide just to say fibrosis is a huge unmet medical need. Lots of different causes of fibrosis, lots of different activators. Almost half of us will ultimately be dealing with some kind of chronic fibroproliferative disorder. So it's important to understand these mechanisms and devise new treatments. And I just want to say that while the field of inflammation has really been in existence for more than a century, really, I think fibrosis as a distinct field has really only been appreciated over the past 3 or so decades. So it's really a new field, and we really need to dive in deep. And we only have 2 approvals for an antifibrotic therapy, a specific targeted antifibrotic therapy with pirfenidone and nintedanib, both for idiopathic pulmonary fibrosis and increasing use in interstitial lung disease. So we have a long way to go in this field, and it's really great to have Julian and Florian here today to tell us about the important role that fibrosis plays in inflammatory bowel disease. So I'll hand it off to our organizers and Julian.
So who, if not Julian, is going to discuss, after the first fantastic talk, he's going to discuss how we assess and how we treat fibrostenotic disease in patients with inflammatory bowel diseases. Thank you so much, Julian.
Thanks very much, Iris, for your words. In this talk, with this particular talk, we will address 2 clinical issues in the field of fibrosis. One is the how do we assess a stenotic lesion, a fibrotic lesion, the amount of fibrosis, and how do we manage these fibrotic lesions. And although my title refers to IBD, I will mainly focus on Crohn's disease. In terms of assessment, we first have to look at morphologic characteristics, of course, location where a stenotic lesion lies, but very importantly also we need a precise estimation of length, because that determines the probability to get a successful medical or endoscopic treatment. And also, if there is an angulation in the stenosis, I apologize because I only knew today that I would not be able to mark my slides to show you where the lesions are. But I'm sure that every one of you can identify here a very angulated and long stenosis, and of course, this angulated stenosis would not be amenable to endoscopic therapy. In addition to the precise characterization of a particular stenosis, we need also a full assessment of the potential existence of other stenotic lesions, which is not infrequent that a patient with a stenosis has additional lesions. And for that, the recommendation is to use MRI. As you can see in the left, the stenosis in the terminal ileum could be easily identified also by ultrasonography, but deeper stenosis, as you may see in the middle and right slides, in the mid or more proximal ileum could be missed by ultrasonography. Then we have to be sure whether the stenosis is associated with complications. And this slide is kind of a gamut in complications of stenosis. You will identify in the right upper quadrant segment of the small bowel with thickened wall, and you will see that in the sitting lower there is an intramural abscess. From this intramural abscess, we have a quite high diameter fistula that fits an extramural abscess. This is the whitish image you have in the center, and this abscess is also connected with the bladder, which is the black image you have in the bottom. So intramural abscess and also prestenotic dilatation, fistula, and extramural abscess. These are aspects that will also be determinants of our treatment choice. But probably what most of you would consider the holy grail of assessing stenosis is whether the stenosis, the lesion, is inflammatory or fibrotic, inflammation versus fibrosis. But unfortunately, fortunately, life is not black and white. Life is in color. And most of the lesions would sit in the middle between what you see in the left, which is a highly predominant inflammatory lesion, and in the right, that is this bluish image that marks the fibrotic tissue. Most of the lesions would sit in the middle. And we have had the opportunity in a collaborative European study to quantify the relationship between fibrosis and inflammation. And we use for that, in a multi-center study, 61 specimens that have been resected. So those are surgical specimens. And it is very clear that there is a correlation between the degree of inflammation and the degree of fibrosis. Most of the lesions are in the diagonal of this square. And you may see that only 6 of grade 3 fibrosis lesions had only an inflammatory score of 1. So only 6 of 60 were predominantly fibrotic. The rest had mixed component of inflammation and fibrosis. And there have been many attempts to use the classical known parameters in Crohn's disease, alterations associated with Crohn's disease, to measure inflammation and or fibrosis. And here I show you examples of thickening, hyperenhancement, edema, ulcers, stratification. But remember that the first 4, thickening, enhancement, edema, and ulcers, are components of the every time more widely used Maria score, which is a score of inflammation. And when we used in studies using these findings to categorize the lesions as inflammatory or fibrotic, came to complete contradictory results. I show you here 2 studies, one of Zappa, one of Pungwani, and while the components associated with inflammation were similar in the 2 studies, the components that were associated with fibrosis were completely different. The findings were completely different in the 2 studies. So these classical findings, classical MRI findings, are not useful to distinguish between inflammation and fibrosis, and we need other approaches. One of these alternative approaches has been to characterize how fast a lesion is saturated by contrast, what we call enhancement, early or late enhancement. And this is based on the fact, as I show you in this first picture in the middle, in black and white, that lesions without fibrosis have a rich vasculature, whereas fibrotic lesions have a kind of a prune tree vasculature. There are much less vessels. And when we inject contrast in the early phase, the color figure in the middle, there is rapid saturation in a non-fibrotic lesion, but very slow only saturation of the fibrotic lesion in the late phase. This approach, this examination has been used very successfully by cardiologists to characterize the nature of lesions in the myocardium. What about the intestine? Well, in an inflammatory lesion, you see in the first MRI image the stenosis in the terminal ileum at 70 seconds, and you see that at 7 minutes the image is almost the same. Whereas in the lower MRI image, a highly fibrotic lesion has a very low contrast uptake at 70 seconds, and this is dramatically changed at 7 minutes. Okay, so the fibrotic lesions have a delayed enhancement. And when we look at the predictors of presence of fibrosis, we found that there was for every 0.4 for every 1% increase in delayed gain, there was a 0.4 increase in fibrosis, and also the pattern of enhancement homogeneous was associated with fibrosis. So we found two potential predictors of fibrosis. Another approach that has been used is the use of MRI, but another sequence, magnetization transfer. Magnetization transfer basically gives a stronger signal when we have molecules of high molecular size in a tissue. For example, the muscle that has myosin, a molecule with a high molecular size, has a high MT signal. Okay, so collagen, that is also a molecule with a high molecular size, would expect to give a high MT signal. And this is what this Chinese study found. They categorized fibrosis, as you may see in the left figure, in 4 grades from 0 to 3, and you see that there is a progressive increase in the MT signal as the degree of fibrosis increases. And when they wanted to characterize mild versus severe fibrosis with an ROC curve, you see that in the red light, they found a good sensitivity and specificity, better than the contrast enhancement as shown in the green line. Another approach that has been used is diffusion capacity. You see that in these 6 cells here, in the 4 cells in the upper part of the figure, there are no molecules in the interstitium, so water may move freely, but when there are collagen fibers, the movement of water molecules is restricted. And so the apparent diffusion coefficient decreases. And here is what is shown. You may see the graph in the left, that in high fibrosis, there is less apparent diffusion coefficient values, and there is a significant, although not very strong, correlation between diffusion coefficient and the degree of fibrosis in the tissue. So we had 3 potential approaches, and we wanted to determine which one was best: the late enhancement, magnetization transfer, or diffusion coefficient. So we ran a multi-center study in which all the sequences were performed in patients that underwent resection in the next few weeks. And what we found is that the best correlation with fibrosis was found between magnetization transfer and diffusion coefficient. But you see in the bottom left, in the left column of figure shows the fibrosis score, but you may see in the bottom left that the Maria score, the inflammation score, was also highly correlated with fibrosis. And this may be because as I showed you before, there is in the tissue, in fibrotic lesions, inflammation and fibrosis coexist and correlate in degree. So in this study, we could find a potential formula to predict fibrosis based on the use of diffusion coefficient, an inflammatory score, Maria score, and delayed enhancement. But of course, this needs to be validated. In summary, I would say that we have not a precise measure, a technique that could precisely measure the degree of fibrosis in a stricture. And in the second part, I will very briefly summarize the potential medical therapies. And still we have corticosteroids as an option. Corticosteroids, because there is inflammation in those lesions, may afford some improvement. In this very old study already, 96% of patients improved, but improvement was short-lived, and half of the patients required surgery. So we can use corticosteroids to ameliorate the symptoms transiently of these patients. And the only class of drugs that has been specifically tested as a treatment for stenotic lesions is anti-TNF, and this only in one prospective study. There are other retrospective studies, but it has been prospectively assessed only in one study, the Creole study run by or organized by GETED. The primary endpoint was defined as continuing adalimumab treatment without prohibited therapies, and those included corticosteroids, surgeries, or endoscopies. You see that in patients with a stricturing disease at 24 weeks, 62% of the patients achieve the success endpoint. But if you look at the graph on the right, many of these patients over the following years, and we are here talking of a long period, years, lost the benefit. And importantly, in this study, the authors also analyzed which were the factors associated with response to an anti-TNF. And I want to highlight that patients that, among the factors that they identified as significantly associated with success, particularly the duration of obstructive symptoms of less than 5 weeks, short strictures, but short here means less than 12 centimeters, and absence of prestenotic dilatation were predictors of a favorable response to treatment with an anti-TNF. In patients that do not respond or to the anti-TNF, or they have had recurrent stenosis under treatment with anti-TNF, we can offer balloon dilatation. And in this review and meta-analysis from the group of Florian Rieder, you see that technical success is achieved in the majority, 94%, symptomatic improvement in 82%, but half of the patients, or 80% of the patients need redilation. But if you you are ready and the patient is ready to assume redilation, then 50% of the patients will finally escape from surgery. And you should look at if the stenosis is amenable to dilatation, that means less than 5 centimeters and non-angulated, and the presence of fistula and suspected malignancy would be contraindications. In patients having recurrent stenosis, or in which you are not able to dilate with a balloon, you may think of using stricturotomies. And I show here a case that we treated in our unit. It was a case that had been undergone dilatation for 4 times with very early re-stenosis, and then Dr. Begoña González performed stricturotomy, that you use a snare, you perform 3 or 4 cuts, usually in the direction of a Mercedes sign, and this is what she did, and she got a good opening of this recurrent stenosis, and a new endoscopy performed at 4 months. We saw complete opening, and we have followed this patient now for 2 years without re-stenosis. So in patients with recurrent stenosis, stricturotomy may be an option. And finally, surgery is, of course, for patients that are not amenable or fail medical therapy or balloon dilatation, or in the presence of complications, as I showed you in one of the initial slides. We can even think on early surgery in patients with ileocecal stricturing disease, because compared to an anti-TNF therapy, it leads to longer clinical remission. In addition to resection, of course, we can perform a more conservative techniques such as stricturoplasty with different techniques depending on the length of the stenosis. And here, and this is my final slide, I show you a kind of algorithm. Let me stress that we need a good assessment of the clinical symptoms, length of clinical symptoms, imaging characteristics, and if we have a short stricture, short duration of symptoms, no prestenotic dilatations, presence of active inflammation, we may offer, as it's shown on the left, anti-inflammatory therapy, mostly an anti-TNF. If it resolves, then we offer maintenance therapy. If we have some of these factors, 3 or more of these factors, if the stenosis is short, we can offer endoscopic balloon dilatation, and in case of recurrent, stricturotomy. And in long stenosis, if there are no associated complications, we offer stricturoplasty. If we have associated complications in long strictures, we need resection. And with that, I thank you for your kind attention.
Thank you very much, Julian, for this very practical clinical talk and for educating us about fibrostenotic disease in patients with Crohn's disease. I'm sure many of the audience will have questions. Please submit your questions so that we can ask them and discuss them afterwards in the panel discussion. And so that we can get to the panel discussion, our final keynote speaker would be, of course, Florian Rieder. You know Dr. Rieder from the Cleveland Clinic Foundation, where he's the co-director of the IBD unit at the section of gastroenterology, hepatology, and nutrition, and actually also leads the IBD fellowship program in this hospital. Florian Rieder was the head of the Young Echo, and we remember his achievements from that time. And actually, he also initiated, and his interest in fibrosis and fibrostenotic diseases started many years ago. He initiated the first echo workshop on intestinal fibrosis. You still remember that, Florian? So I had the privilege of participating in that one, and already who could have known that after all these years you would be at that position that you are now with all your research and contribution to that field. So Florian is initiating now, and he will tell us about his efforts actually to build pathways to test antifibrotics. So please, Florian.
Thank you very much, Iris. Thank you very much, Vip, for the kind invitation. And this is a very encouraging seminar, and many friends are already involved in this space. And now with Tom Wynn and his expertise on the basic science side of fibrosis, I think we're going to have a lot of fun together in the coming years. So in the next about 13 minutes, I'm going to talk about stricturing disease being a significant unmet need, which was discussed before, but there's a disconnect between the known mechanisms of fibrosis that Tom talked about and this drug pipeline versus no available antifibrotics in Crohn's disease. And we think that the lack of trial endpoints is a major obstacle for progress in the field. And we formed a consortium that is building trial endpoints to test antifibrotics in stricturing Crohn's disease. And the unmet need has been discussed prior, where you have a relapsing remitting disease course in Crohn's disease. And underneath the threshold for clinical obstructive symptoms, patients become clinically apparent with stricturing disease in Crohn's disease and obstruction about 50% of the cases. And this has tremendous consequences that Julian highlighted with surgery and need for endoscopic balloon dilation. There is no selective antifibrotic therapy available in Crohn's disease. And this is in stark contrast to what is in development in other organs in the gut, because there is an accelerating drug development in fibrotic diseases outside of the gut. And when you see on the left the number of clinical trials that are performed in fibrosis across organs, I see a tremendous increase with a primary focus on liver, lung, and skin, but essentially not essentially, but there are no antifibrotics in Crohn's disease. And you can separate this into different mechanisms of actions and different phases of clinical development. And Tom pointed out earlier, pirfenidone and nintedanib being the only two drugs that are approved for fibrotic disorders, in this case, pulmonary fibrosis. So when you go through all of these drugs that are already approved or in development for other fibrotic diseases, there are many, many candidates that could be used from a pathogenetic perspective for blocking fibrosis in the intestine. But there is this big disconnect between the antifibrotics and other organs in the gut, and we think that a lack of clinical trial endpoints is a major obstacle for development of novel drugs in this area. And there's a catch-22 that has been known for about 10 years and more. There is no antifibrotic and there are no endpoints, and you need endpoints to develop antifibrotics, but you also need antifibrotics to develop endpoints because you need to show that endpoints are responsive to therapy. And how do you get out of this catch-22? And then it's commonly accepted to build a framework for a clinical trial design or a framework for definitions using the best expert opinion in this space. And there have been multiple approaches, some of which took already existing endpoints and graded them, but we took a different approach, which is a bottom-up version of that, where we extracted any item that has ever been published in the space of stricturing Crohn's disease. And then we went through an international expert panel to grade all of these items, where 3 rounds took actually over 1 year, with a final item list of more than 100 items of what strictures are, what treatment targets are, what constitutes improvement, and so on. And this has been published in 2018, and we just got an email, in fact, a couple of days ago, that this is one of the most frequently cited papers since it has been published for APT, which highlights, I think, that this is an area of dramatic unmet need and with increasing attention. So what did we do in this consensus panel? So first of all, we looked at what is a stricture on radiology. And this was driven by work from Dominic Bettenborg, who looked at how many definitions exist in the literature for what are strictures in radiology. And in fact, there are more than 24 different definitions on what are strictures in ultrasound, CT, or MRI. So one of the critical steps to reduce that heterogeneity is, in fact, identify how you define a stricture, ideally with high specificity, because initially you do not want to over-treat patients that do not have stricturing disease with an antifibrotic drug. And you see all of these definitions here for endoscopy as well as for cross-sectional imaging. We then went on to define treatment targets, and treatment targets are in accordance with trials for luminal disease, improvement in clinical symptoms and radiologic features, or improvement in clinical symptoms and endoscopic features as treatment targets for fibrostenosis and Crohn's disease. But each of those needs to be clarified. So what in fact constitutes improvement of a stricture on radiology or improvement of a stricture on endoscopy? And again, you find on the right all these definitions, and just one example, for instance, stricture length seems to be, based on observational data, an item that can change dramatically with treatment. So reduction of length of the stricture by 50% is one example, constitutes improvement for stricture treatment on radiology. And all of this ultimately culminated in the development of a proof of concept design for a phase 2 study, randomized controlled trial for stricturing disease. This is a very high-level protocol that since then has been refined in many, many details, including through work from Brian Fagan, through work from Julian Panes and Vip Chairat. But when we had this proof of concept study design, we performed a needs assessment of what tools are critical to actually run a trial of this kind, because this is in a completely uncharted territory. We noted that we need a PRO, radiology stricture index, histopathology index, and so on. And at this point in time, we were very fortunate to be approached by the Helmsley Charitable Trust, who then sponsored this initiative under the umbrella of, we call it the Stenosis Therapy and Antifibrotic Research Consortium. And this is a global initiative with a small operational committee that consists of Brian Fagan, J.G. Fletcher, Vip Chairat, David Bruning, and Mark Baker, as well as myself. And then input and collaborative activities with a lot of experts and societies globally. And Julian Panes had a tremendous positive influence, in fact, on this group, and Iris is joining us as well. And one important component are the industry partners that they can join us. It's free of cost. We share our data, we share our development programs with the sole goal to facilitate testing antifibrotics in stricture Crohn's disease. And we have had success already with the first randomized controlled trial in stricture Crohn's disease starting in the first half of this year. So what are the core projects based on the needs assessment of the consortium? We're developing patient-reported outcome tool based on FDA guidance. We're developing stricture radiology index for MR, for CT, and now also for intestinal ultrasound. But one need that is also unmet is a stricture histopathology index. And why do we need a stricture histopathology index for full thickness pathology when this only can be determined at the time of resection? And we think this is important because currently all available biomarkers for intestinal fibrosis are insufficient. This is something we just submitted a systematic review. No biomarker that has been developed for intestinal fibrosis has ever been able to be validated. And we think it's because the substrate of assessing these biomarkers is poor, and the substrate is stricture histopathology. And again, there are more than a dozen different indices on stricture histopathology available in the literature, and most of them have been developed by gastroenterologists without even the involvement of a histopathologist. So because of this, with the consortium, we are now gathered at the globally leading IBD histopathologists to develop an entirely novel index from scratch. So where do we stand in this program towards a trial for antifibrotics stricture in Crohn's disease? Patient-reported outcome tool, the Strawman Index, will be completed this year. We're currently in the fourth wave of the cognitive interviews. The MR stricture index is complete, and with generous support from an industry partner, we are currently validating stricture index. The CT stricture index has been completed, but we are refining it based on the learning from MR enterography, and the stricture histopathology index will also be completed in 2021. So when you put all of this together, how the consortium group and many collaborators were working on making this happen is a preclinical development program. And Tom nicely talked about all the mechanisms that we know in fibrosis, and many of them can be applied to the gut and can be validated preclinically. I showed you the clinical trial endpoint development program that is now already very advanced and in stages that can support clinical trials in this space. And again, critical are the pharma partners that have the compounds and have the infrastructure to run clinical trials, which then ultimately would support phase 2 proof of concept evaluations. So in the last 13 minutes, we talked about stricture in Crohn's disease being a significant unmet need. There's a clear disconnect between the known mechanisms of fibrosis, the available antifibrotic drug pipeline, and no antifibrotics in Crohn's disease. There's a lack of clinical trial endpoints, which may be a major obstacle, but we feel that clinical trials are now within reach, and the reality proves this because they are starting this year. Because with this stenosis therapy and antifibrotic research consortium, we are now developing endpoints that allow testing of antifibrotics in this space. With this, I would like to thank again Iris for the kind introduction and Vip for the invitation. I'm looking forward to the panel. Thank you very much.
Thank you very much, Florian. This was fantastic. So now I think when we have the scientific background and the pipeline, and when we have what we think that we need to know about background in clinical assessment and know the targets, so we can start the panel discussion. And I will see the questions that you submitted in the messages box that we have here. But until we get them, Tom, so actually Florian just suggested that we don't have antifibrotics because we don't have good assessment of them, and we don't have the tools and the endpoints. But is that like the most important reason? You said that there is only actually 1 or 2 actually approvals for antifibrotic disease, none of them in our field, which lacks that desperately. So what do you think are the major obstacles? And if you can tell us which pathway or pathways do you think will be the coming promising ones for antifibrotics?
Yeah, I think we're in this field of fibrosis. I think we're really behind anti-inflammatories because of the recognition that it's a distinct pathology. I think for decades, um, people just assumed if you target the inflammation, you'll get the fibrosis. So it wasn't even recognized as a distinct discipline. It was sort of the outcome of chronic inflammation. I think what we've learned over the past few decades is that and we've seen that today, that you can have significant progressive fibrosis in the absence of obvious inflammation in that area. Certainly inflammation is a key driver, but it's not the sole mechanism. So I think the obstacle has been an appreciation that we need to think about fibrosis distinctly from inflammation. And we actually, as I said in my brief overview, I think we need to understand how to manipulate inflammation in a way to make it antifibrotic. I think stage one for antifibrotics is and which we've done with pirfenidone and nintedanib, is we have therapeutics now that slow progression. They're not a panacea. They're not a perfect cure, right? They're slowing progression. Patients are largely still progressing on those therapeutics. So that's stage one, identifying, more and better antifibrotics that slow progression. And then stage two will be, how can we reverse it? How can we actually repair the tissue? And there we're going to need to manipulate the inflammatory response to bring in those cells that will degrade the collagen and allow normal tissue architecture to be stitched back. So I think part of it is just recognition of what we need to do and where we need to go.
So actually, we have a great question here. I'm sorry that the letters are too small. We need to develop a treatment to make me see the small letters, but I can see the question, so I can see from whom it is. And it's directed to all, but I'll direct it to actually to Julian, because I think that it goes exactly to what Tom was talking about now. And the question is there a sense for a window of opportunity? Specifically, is there a point where you say, no, I'm not going to treat that because the horses are out of the stable?
Yeah, I think that in patients, and I try to summarize that in my last slide, in patients with long stenosis, more than 12 centimeters, with pre-stenotic dilatation, which is a characteristic, meaning that the stenosis have been sitting there for quite a long time, so the intestine has had time to dilate. If the patient has symptoms also of prolonged duration, and even more if the patient has had other obstructive episodes before related to the same lesion, I think there is not much point in going for medical therapy. And if the stenosis is very long, more than 12 centimeters, then think on resection surgery. If the stenosis is shorter, think of dilation, because we will avoid 50%, not with the first dilation. 80% of the patients will require over time more than one dilation, but dilation is not only avoiding surgery. It's not only the benefit of avoiding surgery, it's the benefit of preserving intestine. Okay, so if there are factors against performing balloon dilatation, endoscopic therapy, whatever it is, stypturotomy, balloon dilatation, we should think on surgery. But if the stenosis is short, we should try endoscopic dilatation, and don't wait too long. Don't wait too long, because if you wait too long, then the percentage of patients that will respond to endoscopy will be lower. And if you have a good, well-established multidisciplinary weekly meetings, you should discuss with these patients with stenosis and see if they require endoscopy and dilatation next week, or they require surgery in 2 weeks. Because if you get huge pre-stenotic dilatations, if you have very close stenosis, then it will end up always in resection. So close monitoring of these patients, early decisions, but and when there is a point that medical therapy will not work, do not wait, and do not, because the condition of the patient may worsen.
I think that we will all agree that multidisciplinary team approach is key to that. Actually, it's key to everything in IBD. There's a question to you, Florian, actually. So it's a long question talking about the collagen genes and asking about, are there specific collagen proteins predominant in the extracellular matrix, and actually asking you, what do we know about the composition of the extracellular matrix in gut fibrosis?
Yes, this is a very good question and a big area of our interest, because we strongly believe in what Tom was saying, that inflammation-independent progression of fibrosis is a big future area. So far, this has been mainly descriptive and restricted to stainings of the major collagen proteins, collagen 1, collagen 3, 4, and so on, that are elevated in strict-string disease. What we have been doing in our own group are two different approaches. One is, what are the matrix molecules secreted by fibroblasts? And this has been accepted a few days ago, and this paper is going to be available in Gut in a few days. And then the other approach we took is look at the entire gut wall and take all cells out. So we decellularized the gut and then did a proteome of strict-string disease versus uninvolved, which is in progress, but revealed some interesting findings. In general, the major collagens are collagen 1 and 3 in strict-string disease, but there are a lot of other matrix molecules and even anti-fibrotic matrix molecules that are upregulated in strict-string disease. So I think the question is very good in that for many years it has been believed just to be filling material, but extracellular matrix is a very active component in inflammation, very active component in fibrosis. And I do think we will find therapies in the matrix that we can test in humans. So it's a very good question.
I definitely agree with you. And actually now to you, Tom, so many good questions. You'll have to stop us, Vip, because I think we can talk for hours. But there's a question to you, Tom, saying, I understand IBD organoids normalize after several passages. What is your experience with developing successful organoids containing different cell populations?
Yeah, that's a really good question. That is a problem. And we're actually working with the hub to basically develop better techniques to get better organoids that we can populate with additional cell types, including macrophages. Of course, we're interested in understanding their role. So we have collaborations outside of Pfizer where we're working on improving upon those techniques. We also had a longstanding collaboration with Draper to develop culture systems where we can incorporate different cell types under flow. So we have a couple different things going on to improve that area. And happy to reach out and talk with people if they want to chat with me offline.
So much for that. And this is a question to all, but actually maybe we'll start with you, Julian, because you contributed so much in biomarkers and understanding ulcerative colitis. We neglected ulcerative colitis in this discussion, but we've been taught that it's a mucosal disease. And in recent years, we're talking more and more about the structural damage. So what do you know, and can you enlighten our eyes on fibrosis or fibrostenotic damage in ulcerative colitis?
Well, in ulcerative colitis, if you have stenosis, the most and by large important question is to rule out cancer. And you should assume that there is cancer until you have passed the stenosis and looked at and have biopsy samples of all the length of the stenotic lesion. But yes, there are very few patients with ulcerative colitis, or at least that we diagnose as ulcerative colitis, that develop stenosis, that develop fibrotic stenosis. And also, we have seen patients that over time develop those tubular structure of the colon with a component, but it's only a component. It's not. You still find inflammatory cells. You still find muscle cells, but in those patients, as well as in stenosis of Crohn's disease, you find a lot of myofibroblasts. So there is a proliferation also of myocytes and that take the shape of myofibroblasts. So it's not purely fibroblast. the end transformation of the cell into a fibroblast. So other cellular components, but yes, they contribute. But really, the difference in terms of the probability of developing stenotic lesions in UC and CD, I would say it's completely different.
Julian, Vip, what do you say? You're the boss.
You're the boss right now. So if you want to continue for a couple more minutes, I think we're good.
I think we have one more question that actually I would like to ask all of you. Maybe you'll start, Florian. So actually, Tom mentioned that this thought that is so hopeful for us, that there will be medications that maybe can disintegrate strictures or fibrostenotic areas, so actually correct them, not only prevent them. But these might be not anti-inflammatory drugs at all. So do you think already about drug combinations? You know the pipeline, you know what you plan in your STAR, very ambitious project. So what do you think about that possibility?
And many people may not believe this. I think that the gut actually has a very good chance for stricture reversal for the reason that Tom mentioned, because in severe strictures, we have much higher degrees of inflammation compared to the lung, liver, or skin, where in end-stage fibrotic disease, actually, there are not as many immune cells. In some diseases, very few immune cells available. So there is a huge amount of turnover, even in what we call end-stage stricturing disease, which allows therapeutic intervention, I think, to a much better degree. So, Iris, I agree with you 100%. I think it has to be a combination therapy. So there will be an anti-inflammatory component for treating strictures. And Julian mentioned the Creole trial, the steroid trials. There's some data on azathioprine in that space. So anti-inflammatories do work in stricturing disease for suppressing the inflammatory component. But then I would add on a remodeling drug. And that could be a drug that Tom mentioned, such as skewing the immune response towards a reversal phenotype, or targeting inflammation-independent mechanisms. Because we know that even if you treat inflammation well, strictures still progress. So I think the future is combination therapy with a conventional anti-inflammatory with a very good safety profile, and then adding in a remodeling or inflammatory phenotype-changing drug.
Maybe with this futuristic statement, we will end this part of the discussion. And thank you all for your presentations and for the wonderful panel discussion. I'm returning this to you back, Vip. Thank you so much.
Great. Well, just thank you again, Iris, Tom, Julian, and Flo, for this fantastic presentation. We covered a lot of ground, and I think as you've highlighted, it's an exciting time. We're going to see the first treatments being developed and tested in the clinic this year. So an exciting time ahead, and a lot of work to do. But you've all been key to realizing this. So with that, I want to thank everyone for joining today. And just as if I could just very quickly give a brief teaser for the next session that we're going to have in April of this year, which will be on the topic of histopathology and how histopathology is integrated into clinical trials today. So watch your emails for more information to come. And with that, again, thank you to the entire panel and all the speakers and everybody who took their time out for joining us. And have a good day and evening wherever you are. Thank you.